Hey everyone, this is Mrs. Lewis, and I am going to go over parenteral nutrition with you. I'm going to try to keep this video short and to the point. This is from your nutrition chapter in your book. In your nutrition chapter, when it talks about parenteral nutrition, it may refer to it as CPN, or Central Parenteral Nutrition. We often refer to it as TPN, Total Parenteral Nutrition, and you're going to hear it called that in the hospital as well, TPN. So TPN or CPN, and then also PPN is also considered parenteral nutrition. And PPN is Peripheral Parenteral Nutrition. And it's basically just administration of nutrients directly into the bloodstream. That's what parenteral nutrition is. Because we've talked about in other levels, you've talked about enteral nutrition or enteral nutrition, and that is like your tube feedings, your NG tube or your PEG tube. Well, this is parenteral, so it's going directly into the bloodstream because there's some reason their nutritional needs, we need to meet a goal for their nutrition. So what exactly is it? It's a solution with concentrated nutrition to provide adequate nutritional support to a client who cannot maintain nutrition through oral intake or tube feedings. So that's exactly what it is. What is it made up of? What is its composition? Well, it's a high concentration of dextrose, so lots of sugar, amino acids, fat emulsion, electrolytes, minerals, trace elements, and vitamins. And it's very patient specific. It's customized to meet their needs. You'll be drawing blood on them every single morning. Well, if you work night shift, you'll be drawing it. And it's very patient specific. What kind of patient needs TPN? Well, anybody who has an inability to feed the gut. So if their GI tract is not working properly, then they definitely need it. Hyperemesis gravidorum, so your patient that you learned about in level 3, they're pregnant and they can't keep anything down. Intestinal obstruction, so someone that their GI tract's not working because of obstruction. Anorexia nervosa is a type of patient that might need it. Chronic and severe diarrhea and vomiting, or intractable diarrhea. Cancer, often because of the obstruction, effects of radiation or chemotherapy, will sometimes need it. And critically ill patients that are unable to meet their caloric needs due to illness, or being physically unable to digest food or ingest food. Think of your burn patient, someone that's had like major surgery, trauma. So any of those patients would also be good candidates. They often, again, it's per hospital policy, but if you've got a patient, they're not eating, they've had major surgery and they've tried them on clear liquids, they're nauseated, they're not doing well, they normally won't let them continue to just not eat. Usually after about 5 days or so, depending on the doctor, I have seen it go 7, they'll start looking at giving them some parenteral nutrition. How is it delivered? Well, it's delivered through a central line, and that could be a internal jugular or a PIC line, even subclavian. Any of those are generally how it's delivered, and you want to make sure that there's an x-ray done before you give them this hypertonic fluid. So if they get a central line placed, they have an order for TPN, you want to make sure that you get a chest x-ray. And then you also want to make sure that you use a pump. It needs to be on a pump, an IV pump, and there also needs to be a filter used. And this is not the best picture of a filter, but this is your filter here, and you always need to use a filter. side effects or complications. Well, you got to think about, okay, we just said they have a central line, right? So if they have a central access device, then any kind of problem that could occur with that could occur with this. So you could get, they could get definitely some infection, localized and systemic infection because of that, right? Also, any kind of air embolus, hemo, pneumo, hydrothorax, hemorrhage, thrombosis, any of that can occur, but just simply because you've got IV therapy going in, but you've also got a central line. You want to think also that there could definitely be some hyper and hypoglycemia, again, because of the increased sugar content, and you're most likely going to be covering them with insulin. So either or. And they could definitely have some altered renal function because of the hypertonic solution. You want to think also that refeeding syndrome is characterized just by fluid retention and electrolyte imbalances. So you're going to see hypophosphatemia, hypokalemia. Hypophosphatemia is a hallmark of refeeding syndrome. You got to think someone that's malnutritioned and all of a sudden they're on aggressive nutritional support. You could possibly see some problems, and especially some electrolyte problems. You know, electrolyte problems can cause cardiac dysrhythmias, which is an emergency, can be an emergency. So just keep that in mind, that refeeding syndrome is one. Fluid volume and electrolyte imbalance goes with that, but it can be mild as well. So you're going to be monitoring your patient's lab work and monitoring your patient closely. Essential fatty acid, vitamin, trace element deficiency. So any of those they can become deficient. And then I already said altered renal function can be a complication. And then I wanted you to just see, as you see here, this is your TPN, and this is your fat emulsion. Sometimes they can put a little bit of fat emulsion in the TPN, but typically a lot of your patients will have a separate bag of fat emulsion. And that is just someone that needs extra fatty acids. They provide a large number of calories, and especially it's beneficial if the patient's at risk for fluid overload. Of course, they need to check their triglycerides first, and sometimes they're contraindicated if someone's got hyperlipidemia or if they're at risk for a fat embolism. Sometimes immediate trauma, or they won't always start the fat emulsions immediately. So again, you got to check your order, what your doctor wants, but that is a possibility, and that's what that is there. I just wanted to make sure you knew what that was, and I figured you'd ask me later, why is there two different ones there, Mrs. Lewis? So that is why I wanted to make sure you saw both of those. And so what are some complications? Again, metabolic complications that we just talked about. So that is why we want to start slowly and we want to end slowly. So anytime they are started on TPN, it's going to be titrated. So you're going to start them really slow and you're going to increase it. Because what are we trying to do? We're trying to keep the patient in homeostasis, right? We want to keep them in balance. We don't want to overload them. So we always want to start slowly and then end slowly, because again, we want to keep them in balance. So what would be a problem, do you think, if you just abruptly stopped it? Well, they could probably have some hypoglycemia, right? If you're all of a sudden giving them a lot of sugar and then you just stop all of a sudden. So if you have to stop it suddenly for whatever reason, or if somebody stopped it for you all of a sudden, you need to hang D10. So you would hang D10 if it was stopped. Again, I already said use a pump. Always use a pump for these patients. And then you want to check your bag. Of course, you're always going to check your bag for contaminants, just like you would any IV fluid. You're going to keep this bag refrigerated. And you want to only take it out half an hour before use. So you want to always keep it refrigerated. Never ever add to the bag. You never ever want to add to the bag or the tubing. So you never want to push anything through those ports. So you definitely want to have a dedicated line for your TPN. So never draw blood from that line either. You will skew your lab results. And you don't want to have messed up lab results because, again, this is very patient specific, and you don't want to have abnormal lab results when they are using the labs for what the patient needs as far as electrolytes and stuff. And then you also verify the contents with another nurse. So you're going to check your order with another nurse, and you're going to co-sign in your electronic medical record. So keep all of that in mind. This is nursing care, which is very important, right? Again, change your dressing per protocol. Again, that's for your central line, and most hospitals do it every 7 days, but you just want to make sure that you know the policy. Change the bag and tubing every 24 hours according to your hospital policy. Some hospitals are changing that up a little depending on if they have both TPN and the fat emulsion going. So always know your hospital policy. But we generally say, and your book says, to change the bag and tubing every 24 hours. And you always want to use a filter. And then some more nursing care is finger stick glucoses every 4 to 6 hours with sliding scale coverage. And you want to expect slightly elevated blood glucoses because, again, you have a large amount of dextrose. It can be, up to 100 to 150 grams of dextrose daily. So they're going to need glucose checks with insulin coverage. You want to also make sure you're doing daily weights. Because, again, a big problem can be fluid overload. What are the signs and symptoms of fluid overload? This is something, of course you need to know those. So that's why you're going to do your daily weights. And then you want to monitor your I's and O's. Are they peeing okay? Are they voiding? Are they going to the bathroom? So you're going to monitor your I's and O's. And then I'm going to talk briefly about peripheral parenteral nutrition. It's delivered through a catheter in a large peripheral vein, so it's just an IV site. It's short-term use, 7 to 10 days. And usually these patients, their protein and calorie requirements are not as high, so they might be on a diet, or they might be on a clear liquid diet, or they might be getting some shakes. And so they can be self-limited with PO intake. And then with these patients, you're going to give D5 if there's a need to emergently stop it. So you're going to hang a D5 IV solution if the peripheral parenteral nutrition, or PPN, has to be stopped. And that is all I have. If you have any questions, please reach out to your instructor or to myself, and definitely read in your book. And you have a great day, and I will see you soon.